14%. That's a huge difference.
Well, that's 5% of the previous percent on the other page, or 5%?
Yes.
Okay.
Remember, there's 268 total that they looked at. So that's pretty significant just in percentages. Now, if they had looked at more, you can extrapolate that out to 1,000. How many would that be? Okay. This is what they came up with. They felt that vasopressin and epi helps the CNS microcirculation during CPR, and steroids enhance vasopressin's beneficial effects. What do steroids do? Let's talk about that first of all. What do they do at the cellular level? They stabilize mast cells in the cell membrane. Okay. Do you remember how the cascade works for, let's take allergic reactions. Okay. You remember how that cascade works with the release of particular cellular toxins, bradykinins, cytokines. I mentioned this sometime in the past. Things that cause cell death. Mast cells are part of this. The steroids inhibit some of that destruction and release of those toxic reactive substances. Okay? It helps block some of that. So therefore, you don't get as much cell death. Now, many, many years ago, when I started in 1980, we used to give 100 milligrams of Decadron to cardiac arrest, never understanding if it worked and why it would work. But that's what we used to do. That was pretty standard therapy. Fell out of vogue. Nobody could understand what it was supposed to be doing. They didn't seem to get it. Nobody seemed to survive longer with it. But the question remains, did it help the neurologic outcome at all? Did it make any difference in those patients? And who knows, because that wasn't something that was checked. Now, with this study and the use of the solumedrol, which is again like Decadron, it's a steroid, they're suggesting that, you know what, this may result in a favorable outcome to these people. They looked at it again, and this is a journal called Resuscitation. I'm sure you've seen it. And they looked at, again, what is the result of that pause after a shock. Now, the pause wasn't 20 seconds. This was only a short pause of 3 to 5 seconds before they resumed CPR. And what they did is they looked at 2,000 patients pre and post shock times, and they wanted to see, was there a difference of survival to discharge? Now, this is important because remember that Japan study, and there's a lot of studies that come out of Japan and Greece and whatnot. But in that Japan study, we don't know if any of those patients survived the discharge. We don't know that. We only know they were alive at the end of CPR, or if you want to call it alive. So in this grouping of patients, they're looking at survival to discharge, and this is usually meant at 30 days is what this is talking about. They don't mean just that 5 days later they went home. They look at it to 30 days most of the time. Okay? So that's important to understand. You want to look at something that you know, okay, well, we looked at this study, and at 30 days, 90% of the people were alive, you know, as opposed to 5 hours after whatever it was, CPR or whatever, 100% were alive. So that's important to know because things happen after the initial CPR that result in death. Okay, you can actually read this easier now. It is an online in December in Resuscitation if you want to look at the actual metadata and the metrics of how they looked at this. This basically are the metrics right here. So, 29% of the patients had a pre-shock pause of greater than 20 seconds. The median time was 15 seconds. 6.5% had a post-shock pause of greater than 20 seconds. And there should have been two groups, doesn't say. There's another group with a median time of CPR was 6 seconds. So you have two different groups, okay, with lower times to post-shock pauses, or a lower percentage of post-shock pauses. So what happened to these it takes you 20 seconds before you do anything, CPR or shock them again, what do you think is gonna happen? They're gonna die. So what they're saying is, you should not take more than 10 seconds between shots in these ventricular dysrhythmias to reshock a patient and to initiate CPR within those 10 seconds. That the result is a greater death rate. Does that really have to be studied? Did you have to know that to, I mean, is that not common sense to you? Law that's changed in CPR? All they're saying is be ready to shock before you stop the CPR, which I think we do that with the changes in ACLS. And they want you to do it simultaneously. Interestingly, what they don't talk about in here is how many patients, how many operators were shocked during this study. And believe it or not, about 12% of the people doing it got shocked because they didn't have their hands off the patient, or they were kneeling next to the patient, and the other operator hit the button and the guy was still touching the victim. So you don't see that here. It's in the body of the report. That looks like a really barbaric device, doesn't it?
Is that the number we should strive for, the 12%?
No, the point being, you just don't want to take too much time between, that's all. You know, this study I looked at, and I don't agree with what they found, or I don't agree with their conclusions. What they're saying here is that everybody should have a pre-hospital ECG because it saves 20 to 30 minutes when you get to the hospital on that patient having an EKG done. Now, I've not ever worked in an ER where a patient came in by ambulance with any kind of cardiac complaint didn't get put on a stretcher and have an EKG right away. Have you seen that in your, even during season here? Do you bring a patient to the hospital in chest pain who sits there for 20 minutes before anybody even sees him or does an
Now
EKG?
the way lead works, if you don't have, they don't have an EKG in 10 minutes through the door, you're getting dinged for that.
That's what I mean. So in my mind, the only thing that in my mind is valid here is this last statement.
P14.
Okay?
Yeah.
That's the only thing in my mind, is it establishes EMS as a vital first link. They want to say they need EMS and paramedics to do EKGs because it's a vital first link. Now, granted, if you're doing an EKG to rule out a STEMI, to take them to a STEMI center, which is the standard of care, then that's perfectly valid.
It's,
And I see no problem with that. And that's the way this should have read, but it's not the way it read, it's not how it was presented.
Yeah, that's,
no problem.
They looked at a couple of questions in this article, and they looked at these three things, particularly how often does EMS's EKG change ED management? How often are the EMS's EKG abnormalities gone by ED arrival? And prospective study, 281 patients in Ontario, and this means that this was done ongoing. So they looked at these issues here, and they came up with a recommendation. Out of these patients, how many did we say there were? 281? Yeah, okay. So they looked at this and they said, well, how many abnormal EKGs versus normal EKGs changed, or resulted in change of care? This actually is done the other way. How many did not result in any change of care? 12.5%. 65% resulted in change of care on arrival to the ED. Now, again, you're talking about a STEMI, that makes sense, right? How many times have you done EKGs on chest pain patients that didn't show a damn thing? Does that mean they're not having a heart attack? Not at all. just means they don't have a STEMI, but doesn't mean they can't be having a heart attack. They also looked at, well, how many EKGs that were done pre-hospital changed by the time they got there? And they said, well, let's see, ST depression, 11 of them changed. T-wave inversions, 4 of them changed. ST elevation, 2 of them changed. Now, as an ER physician, I have a patient that comes in with complaints of chest pain or whatever, and I see an EKG you've done that shows me this, and I do one that's normal, am I going to send that patient home? No, I mean, so it does not impact my care. So when I look at this, I wonder, so are you telling me that if these doctors didn't see those original EKGs, they would just sent the patient home and said, oh, there's nothing wrong with it? They don't address that in particular. They do say that the ECG by EMS did change management in 2/3 of these patients, which I would hope so. But my point being is that their history alone still should have made them, available for admission. But again, this is in the Canadian healthcare system, so.
That would lead you to, I mean, if there was an abnormal in the field and a normal in the ER, that would lead you to more
Yeah, you would think. Well, but we can see that in patients that have ischemic changes in their EKGs. I've seen where they can come in with ischemic changes, ST segment changes, and over the course of a few minutes, those ST segments go back to normal. So the question would be, if you didn't do an EKG and they came in, and you saw a normal EKG, would that tend to make you think that there was nothing going on with that patient? You see, and yeah, it could do that. So there is value to pre-hospital EKGs. And the value is that it may change the outcome of those patients. So that last statement that they made about it being the vital first link, yeah, it is that, but more importantly, it may show you something significant. So it is something that should be done. Not because it improves a 20 to 30 minute delay, it does not, because that's not how we work down here. But maybe in Canada, that's how they work. Therapeutic hypothermia. There are protocols in most of the hospitals I work in for therapeutic hypothermia in post-cardiac arrest patients. And all you do is put in initiate hypothermic protocol. And they do the cold packs and all that. They looked at these patients, almost 1,000 of them in Europe and Australia. And they wanted to see, well, what happened with these people? What were their outcomes with therapeutic hypothermia, and what temperature did we need to use? So they looked at VFib, VTAC, asystole, and PEA. And you can see the breakdown. 80% were ventricular, 20% were asystolic, and 12 and 7%. Was that 12? 7%? 12. I'm sorry. 12% were asystolic, and 7% were PEA. So they looked at these patients with these two temperature ranges. And they broke it down a little bit more. There was no unwitnessed asystole, so that means all the asystole patients were witnessed. There was 24% that were given IV cold fluids, and 76% were surface cooled. There was a total of 28 hours of cooling, and they were then rewarmed at 0.5 of a degree an hour. And they looked at these, and I'm going to say 1,000, it's easier to remember. They looked at these 1,000 patients, and just look at these numbers. You have survival with poor neuro, survival with poor neuro. Look at these numbers. You really think there's much difference there? So they had 52% of the patients survive, 54% of them had poor neuro function. Same thing here, at 33 degrees, they had 53% survive with 52% of poor neuro function. at then hypothermia versus normal temp survival and neuro outcomes. 36 degrees, 52. I mean, these numbers are almost exact. And this is what I wanted you to get. Therapeutic hypothermia, whether or not this is going to be continued is unclear if it's beneficial. They do say you don't want to be hyperthermic. We don't know what temp works. It may be 35 to 36, which means they're going to be a little warmer. Doesn't have to be 32 to 34. But really, there's no conclusive information that's been obtained from this. They looked at whether or not the pre-hospital hypothermia improves neurologic status amongst cardiac arrest. In this study, they only looked at 583 with VFib and 776 without VFib. They were all cooled on hospital arrival. There was almost 1,400 patients. A lot of patients. Probably a decent number to get decent data. EMS cooled them at 2 liters of 4%, 4 degrees Celsius of lactated ringers. They decreased the core temp by 1.2 degrees Celsius en route to the ED. So what did the ED said? That, oh, well, it took us less time to get them to 34 degrees. And what kind of results did we have? Well, EMS patients got Pavulon and Valium. Why do you think they got Pavulon and Valium? Pavulon and Valium are used for intubation. So, what were the outcomes? Look at these numbers. A little bit of difference here, maybe. Interestingly, they would say this was no different. If this were reversed, they'd say there was a difference. And it would be beneficial to do therapeutic. So you have to watch some of the nomenclature they use and how they interpret some of this, but that's what they would say. Since it turned out this way, they'd say, oh, well, gee, VFib in the EMS patients without therapeutic hypothermia, oh, it's really negligible, the percentage. And okay, the percentage is less than 10%, but there is a difference. And that's the important thing to remember. They would say here that there's a big difference, and in fact, it's about 3%. So what did they say after they looked at this? Well, they didn't think there really was much in the way of improvement in neurostatus in any of the groups with therapeutic hypothermia by EMS as opposed to just in the hospital. They did say that they thought the EMS therapeutic hypothermia had more rearrest. Now, why was this? Well, maybe this was from the temperature difference. Maybe this was from electrolyte imbalance. Don't know. They did say the hypothermia group that EMS implemented, there's a greater percentage had pulmonary edema. Well, why was this? Was this because they had more significant shock? More significant damage, myocardial damage? Don't know. I can't believe it was purely because of this, therapeutic hypothermia. And the pressor use in both groups was about the same. I think what you just need to know out of this is that there really wasn't much in the way of neurostatus improvement in either group. So again, it goes back to that statement, we really don't know if therapeutic hypothermia is beneficial in these patients. You mean in pressure use? Or
the hypothermic use is in addition.
Yeah, this is hypothermia is the main thing they did, and then whatever drugs they did. They didn't separate drug use, no drug use. It was a very simple study, just yes and no. Yes, it was given by EMS. No, it wasn't, because it was all done at the hospital for everybody. So they didn't separate out the pressures and whatnot. Now, do we know that those meds, Pavulon and Valium, cause anything? Do you guys know what pavulon can cause? It can cause a hypothermic reaction. So you can get a temp. Many of the muscle relaxers can do that. And a lot of the general anesthetics can do that. It's called malignant hyperthermia. And it's drug-induced. You can check that when you have time, look it up, and we'll talk to you about it.
Is that because of metabolic changes?
It's because of changes in the brain and your temperature regulatory section of your brain. That's how it does it. And then you get rhabdomyolysis and all the things that occur with it. So what's the take-home message with this? Whoops. No, it's the same patient. Therapeutic hypothermia by EMS offers no benefits. Tell that to EMS. Lots of EMS training, resources, and expense, yet no benefits shown. Now, this is from 2014, these studies. They were just presented. So do we all have to rush out and buy ice to keep our saline in? No. I think this is the last one. Is oxygen dangerous? Well, you know, this has been a big issue for the last several years, starting with intubation. The most recent statement I've seen made that one of the medics told me from EMS was that now they just want us to put a nasal cannula on the patient and turn it on even during CPR. Because there's a couple studies that suggest that you can absorb some O2 passively during CPR with just a cannula blowing oxygen past your nose. So what do? Well, they looked at 170 patients. And again, what does this mean? Retrospectively. They went back and looked at the data. This wasn't an ongoing study. Okay? They looked at their PaO2, which is a blood gas analysis of their oxygen. They looked at deaths and neuro outcomes. And they noticed that the highest oxygen use was in the first 24 hours. They also looked at it besides the cardiac arrest. I think the first one was cardiac arrest, second one was stroke. This one was a huge study. 8,500 patients and 84 ICUs. That is a lot of patients. They looked at ischemic strokes, subarachnoid hemorrhages, and hemorrhagic strokes. They looked at three groups: hypoxic, normal, and hyperoxia, too much oxygen. And they define hyperoxia as a PaO2 of greater than 300. We don't usually see that, and if I get a gas on a patient who's intubated and it comes back that high, we cut their O2 percentage down. And sometimes slow their ventilations. It depends on what we're setting. So, remember I mentioned some things about vasoconstriction. So we know this now. And this would be a good article just to pull up from critical care, just to have in your armamentarium. It's only one page to read. Be good to have. What happens in hyperoxemia, or hyperoxia is the medical term. In stroke, it causes cerebral vasoconstriction. In MI, it causes coronary vasoconstriction. We know in COPD, it decreases their oxygen drive, knocks them off the oxygen hemoglobin dissociation curve. So what happens? They stop breathing, is what this means. Too much oxygen in COPD, they stop breathing. Status post-cardiac arrest, they have a decreased neurological recovery. This is only recent data, the last probably 5 to 8 years that started suggesting this. Sepsis, now here's something we didn't know. They have impaired O2 delivery. So by making them hyperperoxia, you make this worse and they get more tissue hypoxia. Hemorrhagic shock, compromised hemodynamics, comes back to these things right here. what the author suggests is this is only a page, has 61 references. O2 sat of 92 to 94% is what to aim for in your patients in the field. There's no evidence that greater than 98 or greater than this, 92, 94%, is beneficial, and lots of evidence that hyperoxia has significant potential deleterious effects. Critical Care 2013, volume 17, pages 313 to 314. Pull it up. 92 to 94 in the normal patient, that's what we shoot for. 89 to 92% in COPD. So you should not be bringing patients to the ER with O2 sats of 98% who have COPD. And the same thing when it comes to oxygen in general. This is what the data suggests. Have that article in your back pocket, so when somebody says something to you, you whip it out and say, well, according to this review of 61 references, these are the numbers that you should be striving for. So we looked at these things. We understand this we don't do anymore. And these are the general summaries. Consider vasopressin, steroids, and epinephrine for cardiac arrest. EKG pre-hospital, which we already do this. We don't have to worry about that. Perishock pause, less than 10 seconds between shocks. They're espousing you do it as quickly as possible. If you're going to do therapeutic hypothermia, they think you should do it at 35 to 36 degrees and not 32 to 34 degrees. And the new norms for oxygenation pulse oximeters is 89 to 92% for COPDers and 94 to 95% for everybody else. Okay. That's it, folks. You can go online. I asked Greg to send you all this link. This is really good. I'll show you. I don't know if he's signed on to the whole thing here. Let me see. This is an interesting article. It's local, so you can pull that up too. Okay. Let me back this up and you'll see what it looks like. So, this is what you'll go to. You'll see all the years, and you can pull up the year's lectures, what they had during that weekend, and as you see, there's a lot of topics. It's usually current thinking in EMS, and here this one has Geodon in it, ketamine. I was at this one. Pain medicine revision. Nobody from EMS goes there from this county. I wanted to point something out. And this is just something I want to just show you because this is what I'm going to be doing in the next 6 months. We're revising the credentialing process. And if you see here, I will be meeting with Greg and the chief of this agency and the 2 other agencies. Some important points. This is what they do at Austin, Texas. And this is what was interesting. This is from a medical director. That was after that process they had implemented, up to 75% had to go back